Thank you so much for joining in today on a busy Saturday evening for our Cardio Colloquium program.
Sunday
And
evening, not
good evening.
Saturday. Sunday
Sorry.
evening. Today is Sunday.
Yes, a busy Sunday.
Yes, sorry.
So without
And
further ado,
India-Pakistan match is going on.
oh yes, the Pakistan
Yes.
India-Pakistan match is also going on. So with all that and taking much of your time, let me introduce our eminent faculty. We have Dr. Bhattacharya, sir. Definitely doesn't need any introduction. Sir is a director of the cardiology department and a senior interventional cardiologist, the chief of cath labs in Narayana Healthcare in Kolkata. We welcome you here, sir, today for the discussion. Apart from that, we have our eminent faculty of Dr. Piyush Khera. Sir is a consultant cardiologist in the Cardiac Care Clinic, Lucknow, UP. We also have Dr. Archit Daya. Sir is from the ARS Holy Art Advanced Cardiac Care and Research Center in Rohtak, Haryana. And finally, we have Dr. Amit K. Soni. Sir is a chief cardiologist in the Indus Super Speciality Hospital, Mohali, Punjab. With this, I would like to hand it over to Dr. Devdutta Bhattacharya to enlighten us about 30 years of air to ARS navigating RAS inhibitors in post-MI patients. Over to you, sir. You're on mute.
Good evening, everyone. So this is a 1-hour meeting, and we understand that there is an important cricket match going on, so we'll try to keep it brief. So we will go through quickly over 30 years of our experience with ACE inhibition in post-myocardial infarction patients. And I have seen this journey over the past 30 years, beginning when I was in training in cardiology, when all these trials were coming out, and how there was a lot of anxiety about giving this drug in myocardial infarction patients, and how hypotension can occur and how we should protocolize it. And then there was a lot of talk and study on first dose hypotension with ACE inhibitors, particularly ramipril, and how we overcame all that, and how this drug has now become a very standard drug and a very trusted drug in our armamentarium in the post-myocardial infarction patients. How we started, we will have discussions on this, and how this drug has expanded its indication in the treatment of heart failure, in the treatment of cardiovascular disease. The benefits of this drug, everything I think will be in the ambit of this discussion. So let's go to the first slide, please. So in acute myocardial infarction, what choices do we have? We have ARBs, we have ACE inhibitors, and we have ARNIs. Next slide, please. So what is the evidence of ARB in post-myocardial infarction? Let's address that first. We can give you two trials, Optimal 2002 and Valiant 2003. And what the trials show is that there is, between losartan and captopril, there is a non-significant difference in total mortality in favor of captopril. And valsartan is as effective as captopril in patients who are at high risk of cardiovascular events after MI. And finally, combining valsartan with captopril increased the rate of adverse events without improving survival. Next slide, please. So these are the graphs that you can see with the Optimal 2002 trial in myocardial infarction with angiotensin 2 antagonist losartan, and the results you can see, the graphs you can see. And ACE inhibitors, the conclusion clearly is that ACE inhibitors should remain the first choice in treatment after complicated acute myocardial infarction. Next slide, please. And then this again is valsartan in acute myocardial infarction. We have studies with valsartan in heart failure as well. You are all aware of the VALEF study. And what this says is that the mortality from any cause and cause-specific mortality were similar in the three treatment groups, which were valsartan, the captopril, and valsartan plus captopril. However, the rate of adverse events were much greater if you combine valsartan and captopril. This is something that we learned by combining these two drugs in other trials as well. So we don't do it any longer. Next slide, please. Then we have ACE inhibitors. Next slide, please. we'll go to ARNI first. So angiotensin receptor neprilysin inhibition, this is a rage in heart failure. We are all convinced about its beneficial effects in heart failure, and this drug was tested in the Paradise MI trial, and these are the results. Next slide, please. So 0.5 to 7 days post-MI with LVEF of less than 40% with or without pulmonary congestion, and any risk enhancer plus any risk enhancer, namely age greater than 70 years, EGFR less than 60, diabetes, prior MI, atrial fibrillation, LVEF less than 30%, CLIP class greater than 3, STEMI without reperfusion. These were risk enhancers considered in acute myocardial infarction, and major exclusions being prior heart failure, clinical instability, meaning hypotension, and EGFR, meaning less than 30 of EGFR. And there were two groups. One group had 200 BD of sacubitril valsartan, 2830 patients, and ramipril 5 milligrams BD 2831 patients. Primary endpoint being cardiovascular hospitalization, cardiovascular death, heart failure hospitalization, and outpatient development of heart failure, and the secondary endpoint being cardiovascular death or first heart failure optimization. And this was presented in ACEI 2021. Next slide, please. And these were the outcomes, the graphs, and as you can see, the graphs show that the hazard ratio is 0.9. Meaning that there is a non-significant difference between these two groups in the outcomes. Next slide, please. And this is a slightly more detailed analysis, and you can see if you look to your right, the p-values on the right for primary outcomes, cardiovascular death, heart failure hospitalization, and outpatient heart failure are all really not in favor of any drug, except the outpatient heart failure heart failure incidence, which is slightly in favor of sacubitril and valsartan. Next slide, please. And the adverse events, they are more or less similar, except for more hypotension and cough in sacubitril valsartan compared to ramipril. Next slide, please. So the summary is that it did not result in a significantly lower rate of cardiovascular death, heart failure hospitalization, or outpatient heart failure requiring treatment. Pre-specified observations of reductions in both the investigator reports of the primary composite as well as in the total adjudicated events support incremental clinical benefits of sacubitril valsartan. And the safety and tolerability of sacubitril valsartan in this AMI population was comparable to that of ACE inhibitors. So after this, there were questions regarding the benefits of sacubitril valsartan in the post-MI group of patients. Next slide, please. And with this, we come to ACE inhibitors in heart failure in post-MI. And there are many trials. There are selective higher risk long-term trials, and there are broad short-term trials. Next slide, please. Let's go on to the most pivotal trials. This is 1992 SAVE randomized double-blind placebo-controlled multi-center trial, MI with LVF less than 40%, captopril max 50 milligrams TDS, follow-up of 24 to 60 months with a mean of 36 months. And you can see the graphs separating within a year, and then the benefits persist over a period of 4 years, and the graphs continue to separate. And what was the previous slide, please. What was the benefit? It showed a 19% reduction in mortality. Remember, this is relative reduction, and 25% reduction in recurrent myocardial infarction. Most importantly, the cavity dilatation. This we have come to realize that these drugs are extremely important in preserving the LV geometry. We see a lot less of this adverse LV remodeling after myocardial infarction that we used to see 30 years earlier. These patients developed huge LV aneurysms, and they were very difficult to treat thereafter, and their long-term outlook was poor. These benefits occurred equally in patients who received lysis plus beta blockers and those who did not. So this is a very important analytical point. Next slide, please. Then we have the TRACE study, and again, this shows a 25% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. Very similar to the last study, except for in addition, we have this 20% and a reduction in sudden cardiac death. Okay, this is with Trandolapril. Next slide, please. And there are other evidences. These are old trials, ICIS-4 with a large population of patients, GC3 and CCS1, and all of them tend to suggest that in myocardial infarction, especially after anterior wall myocardial infarction, if you treat these patients with captopril, they tend to have a far lower mortality with a very significant p-value here of 0.02. Next slide, please. And this brings us to the AIR study, 1993, again, a randomized double-blind placebo-controlled multi-center trial. And again, what we find here is that similar to captopril, there is a 27% reduction in mortality, relative risk reduction, 19% reduction in the rate of MI and stroke. This is a new finding at 6 months. And as you can see, these graphs, they tend to get wider as you follow it up over a period of time. Next slide, please. And if you follow this up, what conclusion you can reach? So this is followed up to 6 years. And the beneficial effects of Ramipil started early. As you saw that, can you go back to the previous slide? Can you see that the graphs start to separate early within 6 months and they continue to separate? Next slide, please. And the benefits persist. And the beneficial effects started early after myocardial infarction with heart failure and are sustained over 3 to 4 years, despite discontinuation of medication at 1 year. Relative risk reduction in mortality, 6%. An absolute risk reduction of 11%, and treatment of 9 patients with Ramipil for an average of 1 year will result in 1 additional survivor to 5 years. So this is not a big number. So if you treat a relatively small number of patients, you can have this benefit in your cohort of patients, especially in patients with myocardial infarction who had symptoms of heart failure at presentation. Next slide, please. And then there is this long-term survival benefit study, the AIR survival study, which was published in 2021. And this is 29.6 years after randomization. And it assessed the magnitude of impact on length of survival observed after treatment with Ramipil, target dose 5 milligrams twice daily when compared with placebo. And the primary outcome was life expectancy or all-cause mortality. Next slide, please. And here you can see that the median survival time was 8.3 years with placebo and 9.6 years with Ramipil group, with a clear extension of life by 14.5 months. This is not a small matter. And the survival curves cross at 14 years from the time of randomization. So the life expectancy was greatest at 15 years. Life expectancy was improved with Ramipil across all the comorbidity groups. This is a very, very important finding in this group of patients. We know that our patients will not live forever, but you can see that to have a prolonged benefit beyond 15 years of the initiation of treatment, this is very important data, and this data is not present for any other drug. Next slide, please. So these are more detailed analysis, and what you can see is that if you have diabetes, previous myocardial infarction, history of heart failure, hypertension, angina, age greater than 65 years, you can see that there is a clear-cut benefit in favor of the patients who have taken the drug versus the placebo. So if you're diabetic, hypertensive, all these things are very common in your practice, in our practice. So you can see that this very clear-cut benefit in favor of the drug. Next slide, please. So substantial survival gains for every day a patient received ramipril on average. This is another way to look at it. Life was extended by a further day, and relative risk of patient patient with survival with diabetes was increased by 54%. That is a huge number. We know the beneficial effects of ramipril in diabetes because it acts on other organs, namely the kidneys, preserves the health of the kidneys. So there are multiple benefits of this drug, and especially in a myocardial infarction patient with heart failure who also has diabetes, the gains are really huge. Next slide, please. And next slide, please. So the concluding remark, friends, is that treatment with ramipril for about 1 year when started early post myocardial infarction in post-acute myocardial infarction patients with heart failure results in a survival benefit which is sustained over many, many years and offers on average an extension of life of an additional 1 year. So with that, I think we come to the end of this presentation, and now we will go for question and answer session. So next slide, please. Let's go to the questions. Let's go to the questions directly. Yeah. So question to Dr. Piyush Khera: in the post-myocardial infarction, post-revascularization, at what systolic blood pressure do you initiate ACE inhibitor therapy? That question number 1 is for you, and then I will go to the other participants. Dr. Khera.
So after this lucid presentation which you have given, it's clear that initiating ACE inhibitor therapy in post-MI patients would be beneficial, and it's recommended that we should start within 24 hours of the MI. The only point is that there is a cutoff in the blood pressure, because if the blood pressure is too low, then there is a problem. Hypotension will cause further ischemia. So the cutoff of 100 systolic blood pressure is recommended for the starting up of ACE inhibitors in the post-MI setting. But in certain cases, we know that if we carefully monitor even a blood pressure between 90 to 100, we can start with ACE inhibitors in a low dose and then up titrate the therapy according to the hemodynamic response.
True. So I think what we do as cardiologists is we do not want to cause dramatic hypotension, because that really can cause a chain of events which can be detrimental to the outcome. But most of our patients, if they are in heart failure and they have a blood pressure of between 95 and 100, I would go for it. There are a lot of methods by which we have followed over the years. Captopril, we used to have questions in MD and DM about captopril, first dose hypotension and how to overcome it and everything. But I think with ramipril, probably the effect, a small dose of ramipril, it is relatively safe. I am quite confident to give it within 24 hours of acute myocardial infarction, maybe not within the first day. In uncomplicated MI, so if someone has had an anterior wall myocardial infarction, had an angioplasty, and within 6 hours, and the next morning the blood pressure is 100, 110, I would be very happy to give it. I would check the creatinine levels, and I would look for any other signs and symptoms of hypovolemia that might aggravate hypotension. But in general, I agree with you that it is quite safe to give this drug. So what, before we go to the next panelist, what is the starting dose that you recommend?
So for ramipril, I think the starting dose would be around 2.5 milligrams of ramipril once daily. Or if we are facing a very low risk situation, we can even go for 1.25 milligram as the starting dose, but then we need to step up the dose every week till we achieve the target or the highest attainable dose, because finally our goal would be to achieve a 5 milligram twice daily or a 10 milligram once daily dose as we know that the trials have shown maximum benefit with that, and we've been comfortable in using ramipril in these dosages for quite some time since our MDM days, and now we are in a position to uptitrate the dose easily. Especially, we have to monitor the kidney functions, the potassium levels, and the blood pressures.
Exactly. So let me go to Dr. Dahiya. So what is your starting dose in post-myocardial infarction patients with ramipril? And if, say, the patient has been with you for 4 or 5 days before discharge, what is the usual dose at discharge with which the patient goes home of ramipril?
Yeah, usually immediately post intervention, we start the patient. If there's an indication for ACE inhibitors, like the ejection fraction is less than 40%, after post intervention, we start immediately. If there's no contraindication like hypotension, acute kidney injury, or drug allergy, we start with a dose of 1.25. And usually on the next day, we double it up. And if the BP is still high, then we make it 5 mg OD, and we usually discharge the patient on 2.5 or 5 mg OD.
So
And
you discharge the patient at 5 milligrams once daily dosage?
Yeah, so some patients on 2.5, some on 5, but we start on 1.25, and the next day we step up the dose.
Okay, so is it once daily you give ultimately, or you go up to twice daily dosage?
No, we give once daily, and on follow-up we go to 10 mg once daily.
Okay. All right. I think we have Dr. Soni here. Dr. Soni, how do you uptitrate the dose?
Yeah, and before the start, I try to put my patient on SGLT2 plus MRS, not go with the high dose of any ACE inhibitor. Yeah, I think I am. Yeah, you are listening?
Let's talk about post-myocardial infarction patients. As you know,
post-myocardial infarction, my first preference will be I start with the MRS and the SGLT2 together during the admission, and I may discharge the patient if he is having hemodynamic stability for 24 hours and he is off inotrope for 24 hours. I start them ramipril 1.25 and observe them for 1 day and discharge them. Later on, I assess them every 2 weekly whether I can uptitrate the dose or not. I may be able to uptitrate the dose after 2 weeks, or I may not be able to uptitrate the dose. So if a large MI is there and some instability, you cannot shift the patient to 5 mg once daily and patient coming to you after 2 weeks. You have to wait. You have to see the renal parameters and other parameters. But for post-myocardial LV dysfunction, SGLT2 inhibitors, MRA inhibitors are equally important. Don't only ACE inhibitors. Definitely, I start my first drug after MRA and SGLT2 is the ACE. And then if ACE is uptitrated, then I can add only beta blockers. But for me, there is not hurry in jumping to 5 mg once 2 weeks or 5 weeks. I wait for the patient. If he is having hemodynamic stability, then I will uptitrate the dose every 2 weekly. Otherwise, I will go for a longer period of time, maybe 2 weeks, 4 weeks, or maybe 6 weeks to uptitrate the patient. Larger the MI, you know. Poor the year.
Okay, thank you,
patient.
Dr. Soni.
Yeah.
We will come back to this point of view regarding your preference for SGLT2 inhibitors in acute myocardial infarction. We'll discuss this in the end because between SGLT2 inhibitors, ACE inhibitors, and ARNI, we have varying evidences, and we will just go through those evidences once more before we can come to a consensus about which drug we really prefer in this group of patients and the order in which they should be given. So can I go to the next question? So this is for Dr. Soni. Will you switch the patient to an ACE inhibitor if the patient at the time of MI was receiving the ARB for hypertension? Now, ARB we give for hypertension very commonly. So, for example, a patient would be on the most commonly prescribed ARB is telmisartan. So this patient is having telmisartan 80 milligrams or 40 milligrams for hypertension. Now the patient has had an MI, and you have done an intervention. And what will you do with the ARB, Dr. Soni?
Yeah, thank you, doctor. If I haven't done an intervention, already I have to stop these drugs, ACE or ARB, 24 hours, maybe 2 hours before intervention. After that, the first line of the drug, I
Okay,
will
I'm
prefer
telling you,
ACE.
I'm sorry to interrupt. I'm telling you that the blood
Yeah,
pressure,
sorry.
the blood pressure of the patient is 180 by 100 when you took the
Yeah,
patient intervention. So what will you do now?
I probably I will stop the ARBs, and once hemodynamic stability is there, maybe you already know, for starting either an ACE or an ARB or an ARNI, you need 24 hours hemodynamic stability, means patient should be out of any inotropic drug for at least 24 hours. Once, if a patient with 100 BP, his output is okay, his hemodynamic is maintained, I will no hesitation in starting an ACE inhibitor at a dose of 1.25 mg. No hesitation.
So you will switch from ARB to ACE inhibitors. Is that
Yeah,
did I get you right?
ARB are already gone before my operating table.
Yeah.
There is
So
no,
this
no,
patient,
no, no,
remember,
no.
this patient is a hypertensive. Okay,
Yeah, it's okay.
I'll take
He
this.
suffered
I've got your point. So,
Yeah.
Dr. Khera, what would your approach be?
So, what Dr. Soni is saying is also okay, but I feel that if the patient is already on an ARB, theoretically, it's okay. We can shift the patient to an ACE inhibitor after having an acute coronary event. But practically speaking, we don't. We continue that patient on the ARB because you already we are aware that even the ARBs are indicated in patients who probably are intolerant to ACE inhibitors, or the patient has any side effects related to ACE inhibitors, or if the patient is having any contraindication to ACE inhibitors. So ARB, especially telmisartan, is probably equivalent to ramipril as shown in the on-target trial, and we, practically speaking, probably have no strong indication to shift the patient from the ACE inhibitor, from the ARB to the ACE inhibitor. But theoretically, yes, since the benefits of ACE inhibitors outweigh the benefits obtained from ARBs, we are not unjustified or doing something wrong if we shift the patient from the ARB to the conventional ACE inhibitors, either ramipril or perindopril, whichever the case may be.
Okay, I
That
will
is
play the
my
devil's advocate, and I would ask you that if the patient really has hypertension and the patient has been well controlled on a drug like telmisartan, then would you think that it will give you the same antihypertensive effect if you switch to ramipril?
Probably a lesser antihypertensive effect as compared to ARBs, because ARBs have been a stronger antihypertensives as compared to ACE inhibitors practically. Although they would not be agreeing upon it, but I think they are.
Yes. So in this situation, would you consider ARNI instead of ACE inhibitor? I think I'll put this question to Dr. Dahiya. So would you switch from telmisartan to ramipril, or would you go from telmisartan to sacubitril valsartan?
No, I will not prefer switching to any of those drugs. If patient is hemodynamically stable and the BP is well controlled with telmisartan or any other ARBs, I will continue with that. Only in the rare scenario when the systolic blood pressure is around 90 or 100, then I might think of adding ACE inhibitor on discharge. Otherwise, in all other patients, I will prefer continuing with my ARBs. And in rare scenarios of acute heart failure on follow-up, I might switch it to ARNI. But switching to ACE, I don't think it will help in controlling the blood pressures. And eventually, we'll have to stop ACE and again start the patient on ARB to control the blood pressure.
Fair enough. Fair enough. I think, yes, we have had experiences with controlling hypertension with telmisartan, and we know that it is a very effective drug and it works over a period of 24 hours. Sometimes telmisartan itself is not enough. Often we have to combine another second drug in the form of amlodipine or cilnidipine to control the blood pressure. And in the long term, the control of blood pressure will also have a bearing on the cardiovascular health of the patient. So if there is no pressing cause indication for us to, for example, if the patient's blood pressure, some patients' blood pressure remained low after a big myocardial infarction for a long duration of time. And in those cases, you might have to downscale your telmisartan dosage or even stop it because the blood pressure has remained in the low level. In those patients, probably you might consider introduction of an ACE inhibitor in the form of ramipril, which the patient might tolerate a little better because it has a lesser hypotensive effect compared to telmisartan. But I agree that if there is not too many hemodynamic worries, then stopping the telmisartan is not a good idea in these patients. Next slide, please. Let's go to the next slide. So this is the question to Dr. Dahiya. How early do you think an ARNI can be initiated in a patient post-MI? So now we have gone to ARNI.
Yeah, in patients of heart failure, chronic heart failure or acute heart failure.
No. This is not chronic heart failure. This is a patient post-MI. So I want you to break the question in two halves. The first is a patient who has come with myocardial infarction and you are at day 1. And the other is a patient with myocardial infarction who has had it in the past and had it somewhere else, and you are seeing it, let's say, 30 days later in your clinic. So try to answer both these scenarios.
For the patients who have on the day 1 post-MI, there is no additional benefit of adding ARNI over ACE inhibitors or ARBs. As per the blood pressure, I will start the patient on ACE inhibitors, and if the high blood pressure is there, I'll start it on patient on ARBs. We have seen clinically also, in practice also, ARNIs are very notorious for causing the acute kidney injury. Already the patient has gone under intervention. So I will not start the patient on ARNI immediately on the day 1. Very rare scenarios we start ARNI on the hospital setup for post-MI. On the day 30, it depends upon multiple factors like the blood pressure. If I want to switch the patient from ACE inhibitors or ARB to ARNI, if there is any indication or if there are heart failure signs because of that MI, I will plan shifting to ARNI. But if there are no heart failure signs, patient is comfortable, there is no NYHA class 2 or class 3, so I will not switch the patient to ARNI.
Yeah, I think that is a reasonable thing to say, a fair point, that if you have a good combination on which the patient is stable, in the scenario of a recent myocardial infarction, there is very good evidence in favor of not to switch if the patient is quite well on an ACE inhibitor. Okay, and next question, please. Dr. Piyush Khera, post-revascularization, if you find LV systolic dysfunction but without clinical heart failure, will you put the patient on ACE inhibitor or ARNI? So this is immediately after. So a patient has come with myocardial infarction. You have done an angioplasty and EF is less than 40%, but without clinical heart failure. You have to give something. There is no question about that. But would you go for ACE inhibitor or ARNI?
So I would put forward this piece of information, which all of us are aware of, that ARNI is probably not the standard of therapy for post-MI patients yet. So this is one thing which we should know. The second thing is that if I have a patient of an ejection fraction of less than 40%, but with no clinical heart failure signs, I would still prefer the conventional ACE inhibitor in the recommended doses and then uptitrate them according to the BP response rather than shifting the patient or starting the patient on an ARNI in absence of pulmonary congestion or any other risk factors of heart failure or signs of heart failure. So probably my answer would be to this problem would be I would continue with ACE inhibitors rather than shifting the patient to ARNI without clinical heart failure.
Yeah, I think I think we all agree with this. I don't think we need to rotate this question to the other panelists because there is broad agreement in what you're saying. So the next question, please. So in the post-MI patient, post-revascularization, when do you like to start a beta blocker? I think Dr. Soni has already touched on this, but I'm going back to you, Dr. Soni. When would you like to start a beta blocker post-myocardial infarction in an acute myocardial infarction patient who is admitted under you?
Yeah, it's all dependent on the first and the important is LV dysfunction. If someone having a normal EF or just a low EF, the patient will tolerate an ACE and beta in a very comfortable position.
No, I'll give you
But
some.
LV dysfunction.
Hold on a second. The patient has a healthy ejection fraction of less than 40%. The patient is in sinus rhythm. There are no overt signs of heart failure.
And heart rate?
The patient's blood pressure is 110/70. When will you start?
Heart rate? Heart rate, please.
Heart rate is 90.
90. Yeah, I will first and most important the uptitrate dose of an ACE inhibitor maximal. If I am starting with the Remipril, I will not start beta blocker first. I will uptitrate the dose of a Remipril to at least 10 mg once a day. Then only after I will start beta blocker. If dose is not titrated, I may start a beta blocker early.
Dr. Khera, your approach. When will you start the beta blocker?
A more conventional approach that we need to start the beta blocker just after 24 to 48 hours, because if the patient is stabilized and his systolic blood pressure is above 100 and there are no signs of any bradycardia or this cardiogenic shock or any acute decompensation of heart failure, then I would definitely start with a low dose of a beta blocker on day 2 or day 3 and try to build up the dose accordingly. And subsequently, I might even, as Dr. Soni was saying, that we are going to up-titrate the dose of ACE inhibitors, we are going to up-titrate the dose of beta blockers in the subsequent period of time, say around a week or so or 2 weeks or so. But starting a beta blocker on the second or third day is important because that is going to give the patient the benefit related to this reduction in sudden cardiac death, the reduction in arrhythmias, and also improvement in heart function because beta blockers are the mainstay of treatment of heart failure. So my approach would be starting a beta blocker early, not before 24 hours, but definitely after 24 hours of the start of ACE inhibitors.
Okay, so let's go to Dr. Dahiya. So your question is, which will be your preferred beta blocker in this group of patients? And you can also take on the question of how soon you will give the beta blocker.
Regarding how soon to start the beta blocker, we usually started just after post-intervention if there is no contraindication. If the BP is above 100 and the heart rate is 90, we usually start the patient on beta blockers and add other drugs to it.
Which day?
Yes.
Which day?
We immediately, the same day. We start beta blocker on the same day.
Okay.
Because in our hospital, we discharge the patient next day. We keep the patient 24 hours. Most of our patients post-revascularization, we send the next day. We start it immediately and we modify the doses next day and up-titrate it the next day. And then we call the patient a follow-up and then up-titrate it more. But most of the patients.
Hold on a second. This you are saying for uncomplicated MI.
Yes. Yes, uncomplicated, not in failure, and BP above 100 systolic.
Okay.
With heart rate of 90.
So yeah, that is very fair. But say someone you have done an angioplasty, not all your patients will be like this. So someone you have done an angioplasty has ejection fraction of 35%. The blood pressure is 100/70. The heart rate is like nearing 100. There are little bit of crepitations. So these patients will stay with you for 2-3 days minimum. So how do you approach that?
Such patients we usually add ivabradine along with other drugs, not beta blocker.
Okay, fair enough. And will add a ivabradine, and what else will you give?
We add ivabradine. If the ejection fraction is on the lower side, we try to add MRAs. MRA help in as a diuretic also. And
Right.
if required, loop diuretics if the symptoms are there.
Yes.
And regarding the choice of beta blocker, most of the patient has the most common drug is metoprolol. We give metoprolol. Some patients who have bronchospasm or history of COPD, we might give bisoprolol. And in rare patients with resistant hypertension, we may give carvedilol.
Okay. Yeah, fair enough. So at what dose do you, we are talking on beta blocker still, at what dose do you initiate and how do you up titrate? This is for
as we
no, this is not for you. This is for
Okay.
Dr. Piyush Khera.
Okay, thank you.
Okay, so as Dr. Daya has said that we can start with the beta blockers, and the conventional beta blockers offer the management in post-MI setting have been the metoprolol and bisoprolol and some amount of carvedilol, because carvedilol has shown benefits in heart failure, robust benefits in heart failure, but carvedilol has the problem that it has also got an alpha blocking effect, and therefore the hypotensive effect of carvedilol is more pronounced as compared to that with metoprolol and bisoprolol. So by convention, I would still give metoprolol succinate, but I have evidence for bisoprolol also in the same setting, and starting at a low dose of around 12.5 to 25 milligram once daily of metoprolol succinate, and stepping up gradually to around 100 to 200 milligram according to the blood pressure response as well as the maximum tolerated dose of the patient. For bisoprolol, I will start with a 1.25 milligram once daily dose and then subsequently step up to 2.55 and then 10 milligram dose. For carvedilol, in presence of hypotension, I would definitely not prefer, but carvedilol can be also be started in a 3.125 milligram twice daily dose and then tried to step up to a 25 milligram twice daily dose as permissible by the blood pressure effect as well as the heart rate response.
Okay, thank you. And Dr. Soni, will you advise a combination of an ACE inhibitor and a beta blocker in your myocardial infarction patients before they go home?
No. Sure. I am
Okay.
not in a hurry to start a beta blocker. I will first upgrade the dose of an ACE. I may add a ivabradine, but not in a hurry to start a beta blocker if LV dysfunction is important. I will add a beta blocker only after a 4 or 6 weeks period, and no combination once the patient is stabilized. The combination is only advisable once your patient is stabilized with the maximum tolerated doses.
And when
No
do you
combination.
usually discharge your patients post myocardial infarction? What is your average length of stay after you have done an angioplasty in a primary angioplasty in a myocardial?
Myocardial infarction depends upon how the patient present. If patient present in the
average length
window period. If patient it's depend upon where you are working. If a window period is good, you can discharge on a very third day or second day.
Okay.
But if someone is late, then you have to discharge after 4 to 5 days. Some evidence of heart failure is there. But my first preference would be either SGLT, SGLT2, ACE or ARNI.
Okay.
Not in a hurry to start beta blocker.
We will come to that. We will come to that.
Okay.
Will you recommend shifting from ACE inhibitor to ARNI, Dr. Daya?
No, if patient has no signs of heart failure, so I will not recommend shifting from ACE to ARNI.
Okay, I think we have discussed this before. So can we go to the next slide? All right. So this is to all panelists, do you consider NT-proBNP as a deciding marker for choosing ARNI over ramipril? In other words, if the NT-proBNP is very high, would you go for ARNI instead of ramipril? And let's start with Dr. Khera.
So,
there is a trial data report, that if the SGLT2 inhibitor, if the NT-proBNP levels are high, then if you give ARNI to these patients, it has a bearing on the NT-proBNP levels. And then there is some extrapolation in showing that this might have a beneficial effect. So I think the question is coming from that. I mean, I don't think that this has any meaning, but yes, what is your opinion?
If there is a persistent heart failure signs, ejection fraction is on the lower side, less than 40%. And the elevated NT-proBNP is significant, say around more than 800, more than 1000. And we see that the patient is having clinical heart failure and he is not improving. With the conventional ACE inhibitor, I would definitely shift my patient from ACE inhibitor to ARNI because of its incremental benefits of greater LV reverse remodeling, as well as further reduction in cardiovascular morbidity and mortality and heart failure hospitalization, and also strong RAS inhibition with the neprilysin blockade. So I think there is a window for ARNI in post-myocardial infarction patients who are having persistent heart failure despite the optimal dose of ACE inhibitors and beta blockers. There, I
you are
might
talking
shift
down
the patient.
this you are talking down the line, isn't
Down
it?
the line, down
Yeah,
the line.
yeah, okay.
After 1 to 2 weeks of post-MI setting.
Okay, yeah, fair enough. Dr. Dahiya.
As we are getting this NT-proBNP test done only in patients who are suggestive having signs and symptoms of heart failure, so it becomes an indirect correlation. If the patient is symptomatic, having a heart failure, we might go for NT-proBNP test, and if it is higher on the higher side, we might think of switching to ARNI. But if there are no signs and symptoms of heart failure, we will not get NT-proBNP done, and there is no indication of switching to ACE inhibitor to ARNI.
Okay, and finally, Dr. Soni.
Hey, we are talking of a post-MI or it's general chronic
This is
heart failure?
post-MI. This is all the questions are in relation to myocardial infarction. So this is acute post-MI. Maybe this is like 1 month post-MI or 3 months post-MI. Someone has come to you in persistent heart failure and the NT-proBNP level is say 5,000. Would you consider switching?
Yeah, NT-proBNP to me is a prognostic and diagnostic marker, and it is nothing to do on a deciding of a ARNI or a ramipril. All the guidelines, what they recommend, if the patient clinical stage is more important than the NT-proBNP. If patient clinically symptomatic, so please, not in a hurry. If patient is clinically symptomatic, despite on a ACE or ARB, then you can switch those patients to ARNI. Otherwise, NT-proBNP, none of the guidelines is a indicator for deciding between a ARNI or a ramipril. It is only the symptomatic status of the patient which decides whether we can switch from a ramipril to ARNI. It is only the symptomatic status of the patient. Nothing to do with the NT-proBNP. It is just a prognostic or a diagnostic marker for me.
Okay, that's I think that's fair. Let's go to the next slide, please. Will you start an ACE inhibitor in all patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefits? And I think let's have a quick yes or no vote on this.
Yes. Yes.
Yes,
me, yes.
I would definitely start from all patients.
All are yes.
All are yes. Okay, next slide, please. So we have come to the end of the discussion. I think there is one point that we need to discuss a little bit, and that is that is a point that was taken up by Dr. Soni, that he prefers aldactone mineralocorticoid antagonists and SGLT2 inhibitors over beta blockers in acute myocardial infarction, and would not start beta blocker until quite later on in the clinical journey of the patient. So he must have his reasons for it. I would not do that myself. I do not think that SGLT2 inhibitors have that great a role immediately after post-myocardial infarction. They have their beneficial effects long-term in heart failure and in patients with diabetes and with or without heart failure, but with chronic coronary disease states. But in acute myocardial infarction, I think it complicates the matter by increasing by decreasing the window for more effective therapy, which in my experience has been beta blockers and ACE inhibitors and mineralocorticoid antagonists in conjunction with loop diuretics if they're in heart failure. So I would like to have the opinion of Dr. Khera and Dr. Dahiya, one by one. Dr. Khera.
So, as you rightly pointed out, even I don't prefer SGLT2 inhibitors because one thing is there that in acute settings, in a hospitalized patient, and if you see that any patient who's going to undergo surgery, we need to stop SGLT2 inhibitors because they cause this problem related to ketoacidosis, and also probably SGLT2 inhibitors have a role longer down the line, not in the acute MI setting where the patient is unstable. So we need to give the conventional ACE inhibitors, diuretics, beta blockers, and the mineralocorticoid receptor antagonists in the timeline which they have decided. Your preferences might change. You might be a protagonist of a beta blocker first, or a ACE inhibitor first, or MRA first, but definitely an SGLT2 inhibitor to start in acute MI setting, I would be very skeptical and probably not do it.
And Dr. Dahiya.
We don't add SGLT2 inhibitors post-MI. Only in heart failure, we think of adding SGLT2 inhibitors, but all post-MI patients without any signs of heart failure, even if EF is 40%, we don't add SGLT2 inhibitors.
Okay, so Dr. Soni, you are in a minority of 3:1. So I will give you another chance to justify your stance.
Yeah, I am not talking about the SGLT2 in acute MI. I am talking about the SGLT2 in acute MI with LV dysfunction. You can't add beta blocker pre-discharge. It is for clear. If a patient having LV dysfunction, heart failure,
How do you define LV dysfunction?
Yeah, LV dysfunction with pulmonary edema. You call it eclipse 3 or eclipse 4.
No. So
No, sir, I am not in the
would you
controversy.
say anyone?
Anyone who is EF is less, I will
Is
start
then?
them on the mineralocorticoid receptor. There is no contraindication to SGLT2. I will make it clear. You can check it down. You can add. The point is not regarding SGLT2 or the mineralocorticoid receptor. Whatever you like, you can add. But we are talking about whether we can start them on an ARNI or ACE. Yeah, definitely we can start them on a pre-hospital condition, either a ARNI or we can ACE. There is no point of discussion we can start SGLT2 or a mineralocorticoid receptor. There is no contraindication for any of these drugs. Any of these drugs, if patient having dysfunction.
I am asking you why you prefer this over
Not preferring, not preferring. I am definitely, my first molecule would be an ACE or ARNI. But if you look at the seriousness of the patient, if he is having hypotension, if patient is having hypotension, borderline blood pressure 90, what the drug you can add for his LV dysfunction? You can add beta blocker? No. You can add ACE, probably if patient is hemodynamically stable. But for SGLT2, why there is no? For mineralocorticoid receptor, why there is no? We can definitely start patients on these drugs are for LV dysfunction, not an acute MI condition, but for LV dysfunction.
I would agree with this.
I will justify that.
I would agree.
Yeah, you can start an ACE or ARB. We are
I would agree. Please. I would agree with your approach if this was a patient with heart failure and not a patient post-myocardial infarction heart failure. That is the point of contention. We are discussing post-myocardial infarction heart failure.
Yeah, we are talking about the post-MI
heart failure. If your patient was just heart failure, so a patient with heart failure with reduced ejection fraction who has not been well, who is in heart failure, you have seen in the clinic and you have admitted and you find that the blood pressure is borderline, then your approach I agree with. But my point is in acute myocardial infarction setting, where you have this concern that what will happen if I give a beta blocker? What will happen if I give an ACE inhibitor to the blood pressure, right? Do I understand you right?
Yeah, hemodynamic.
That is why you are preferring SGLT2 inhibitors instead of these drugs.
amongst the four pillars post-MI, LV dysfunction, ACE, SGLT2, mineralocorticoid receptor, and beta blocker. There is nothing else. So if we can add safely SGLT2 and mineralocorticoid receptor, that is okay. We can start on any day. Then there is our talk is about we can add a ramipril or a ARNI pre-discharge.
Let me ask let me ask you this question. So SGLT2 inhibitors have been tested in acute myocardial infarction setting.
That they have been tested. They have shown to reduce anti-proBNP. They have been tested, and there is no contraindication acute MI. Unless
do they have the same benefit as ACE inhibitors in terms of mortality?
So we are not. So there is no comparison of SGLT2 with an ACE inhibitor. Definitely, ACE inhibitor is a very important drug, but SGLT2 mineralocorticoid receptor, they are going to be added along with ACE inhibitor, or ARNI.
There is some confusion regarding acute MI, and then this is chronic heart. These 4 pillars are for chronic heart failure. We are talking of acute post-MI setting. Probably there is some confusion. So I don't think SGLT2 inhibitors post-MI setting.
No. So you to take out SGLT2 out. We can start with the mineralocorticoid plus an ACE. ACE is the most important now. Every one of us know ACE or ARNI are the most important.
See, the practice of prescribing medicines in acute myocardial infarction has evolved over the past 40 years. Okay, we started with beta blockers, and we saw that beta blockers had a mortality benefit in myocardial infarction. This view has now come into contention lately, and in those patients whose LV function is more or less normal, probably the beta blocker does not have that much of an effect compared to those who have LV function that is impaired. And there is broad agreement that beta blocker decreases the incidence of sudden cardiac death, especially in the first 1 year of post-myocardial infarction patient. And this is due to the reduction in the chance of arrhythmias. You agree with that?
We all agree.
Yeah. So far as ACE inhibitors are concerned, we know that ACE inhibitors, there is very well established that it has a very big role to play in maintaining the LV geometry. And it has effects on heart failure hospitalization as well as mortality. This trial after trial after trial has shown this. Okay.
All the trials are around 2000.
You have a point there that they are old trials. When the other trials
all are okay.
So we have, so let's go point by point. So these two drugs we have, and these are 20-year data, and you saw the ARS study, which is like 15-year follow-up following myocardial infarction, and the benefits tend to persist. So that is very powerful data, which was not available earlier, and we should take it into account into our practice. So this is what I'm saying. So patients with LV dysfunction, we all agree that they're a very high-risk group of patients, and they die earlier, and they have repeated heart failure hospitalizations. And these two drugs, in my opinion, I very strongly feel about this, that they should be on a beta blocker and an ACE inhibitor, and SGLT2 inhibitors come after that. It has a definite role in the treatment of heart failure. I am not contesting that at all. There are other aspects also where you can give SGLT2 inhibitors that has a beneficial effect on long-term cardiovascular and renal health. That is also undisputed. But this is not the group of patients where we should first think of an SGLT2 inhibitor. That is my point. That is my point. I respect your opinion, and but this is how I feel it should be. Okay, I think we have had a good discussion, and I think we can conclude here if there are no questions in the chat box.
So no, sir, no questions in the chat box. We've had a very insightful discussion, and I'm sure everybody who's heard all of you have gained some clinical pearls, which will help them in their clinical practice. So
okay. And what is the score? How is India doing?
I haven't checked it yet, sir. Maybe somebody else can.
You should have done it.
Yeah, you should have done it. What were you doing? Okay, we'll go and.
We were all, I think, engrossed in the discussion that you were having, so we were all just captivated by the same.
Okay. Thank you, everybody. I think we had a good discussion, Dr. Khera, Dr. Dahiya, Dr. Soni.
Thank you, sir.
And I think we can conclude here.
Thank you. Thank you so much.
Thank you very much.
Thank
Okay, bye-bye.
you.